We all see these patients from time to time. I thought it'd be useful to try and consolidate some of the lessons I've learned, which can hopefully be of help to others. So congenital hand differences by definition is a condition that's typically present at birth. That means it should be immediately obvious. For most of them, should be noticed by the caregiver or parents. That means care should be given from the time of birth, but that doesn't always happen. So what do we do when they present late? These are some of the things I want to cover in this talk. So I've listed them as questions because I don't think we have the answers yet. So first of all, does congenital hand surgery in the older or adult patient mean they have presented late? The definition of late is difficult. It implies that we know there is an ideal time to operate. And if we miss that, we have missed the boat. However, in the literature, it is really lacking in terms of an ideal time to operate on a lot of these conditions. Generally, however, earlier surgery is considered better because there is better cortical adaptation. We all know that polycization in the adult patient doesn't do very well. It allows better incorporation of hand prehension. So this child with amniotic band affecting the first web space should benefit from a release to allow a thumb prehension. It allows less time off school, and we heard earlier from Professor Bake's lecture that they tend to remember less. So ideally, we should see them early, but sometimes they do present late. Why is that so? This is one of our previous papers where we found that even in a good infrastructure like the UK, 88% are still seen within a year and not any earlier. So many are still missed. What happens when we have poor infrastructure in lower resource countries? So let's look at some of the other reasons. They can present late if they have other health problems. So this is a 4-year-old with Pierre-Robin syndrome, airway issues that presented late, and I didn't do anything subsequently. The patient could have been told, or the parent could have been told nothing can be done, like in this child with multiple syndactylies. Sometimes there are parental versus child wishes that need to be taken into account. This is an 18-year-old that presented where the parents refused surgery for him. I think in the East, I think especially an extra thumb is a good luck thumb. This is a 23-year-old lady that came and saw me with Fanconi's anemia. Her mom refused to let her have surgery, and the mom died recently, and she really, really wanted surgery. So I think there's added stress in an adult patient because you really got to make the thumb look better than what she had already because she's lived with it all her life. We talk about the good luck thumb. Sometimes I think this can be taken too far. They are good luck fingers, and in this case, the grandmother refused surgery because these are good luck fingers in this mirror hand. I was surprised to see this 25-year-old with very mild camptodactyly, but to her it was important. And so it's just a very interesting field that I don't think we really know a lot about. Patients can present with late complications of previous surgery. I think, Scott, you mentioned that. I do get a few of this as well. This is a patient that presented with previous syndactyly release. In this case, I did a trident flap and debulking. They can present with late manifestations, and I think the perfect example is Madelung's deformity. So is late presentation always a problem? Sometimes they are. These are cases that we really shouldn't see a very severe constriction band in the older adult. And this 10-year-old child with Apert hand that has been adapting and coping with this until the first web is released. But sometimes they adapt. So typically when I go to low resource countries, and we all see this, the radial dysplasia that has adapted, the thumb hyperplasia that has adapted. And in this patient, I think the right thing to do is not to do anything. Now, we have always been taught that if you have a thumb hyperplasia, a Blau 3B or 4 polycization is always the best answer. Looking at this 58-year-old thalidomide survivor, I thought the same thing. She should have had a polycization until I examined her, and this is what she could do with her index finger. So this really made me rethink the whole concept of whether a polycization is the right thing to do. Now, if we do operate on them, what specific challenges are there? So we need to be aware of the different presentations. A third web syndactyly in a baby doesn't usually present with length discrepancies, but in adults, these length discrepancies are common. Here you can see it at the PIP joint. And in this patient, you can see at the DIP joint, which is makes the whole surgery a little bit more difficult. Usually when I release a syndactyly in a baby, I can get away with a graftless technique. It's quite predictable. In an older child, the moment they hit 3 or 4 years old, the fingers becomes longer, and I usually gotta think about putting in skin grafts, and the flaps are usually narrow and more, just because the fingers have changed in shape. So I gotta think about that. But in most surgeries, the principles are the same. As we see in these thumb duplication cases, we do the same thing as Soman has mentioned. We may need to use different instrumentations. We need to use the saw instead of the knife, and we may have to use different methods of fixation. But generally, nothing much else is different. Let me end with this, because I really don't think a lot has been published in this area. What happens to these children as they grow much older? And I would just want to end with this study that we published a few years ago, looking at patients with thalidomide. So I had the privilege of examining them when they were in their late 20s. In 1997, and then in 2023, they are in their late 50s. So the mean age of 58, and we surveyed 127 of them. 50% of these underwent surgery as children. So the survey was anonymous, but we managed to get their diagnosis by asking them whether they have missing fingers or whether they have a radially angulated wrist. And we managed to get quite a lot of meaningful information from them. Now, the results were fascinating. So the mean quick dash was 54.3, and this is pretty high. That means their function isn't great. And what we found was that the quick dash correlates with a worsening EQ5D. That means the hand function correlates with a poor quality of health. So we don't have a lot of data in patients who are this old, and we got to really think about what happens to them when they grow older. Interestingly, the poor results correlated with radio deficiency, finger changes, and when they have multiple congenital hand differences. Now, this is interesting. This really made me think about how to manage radiodysplasia. So this is one of the gentlemen who had a radiodysplasia, and what he lacked was pronosupination, and as a result of that, he compensated with his shoulder, and as a result of that, he developed a reverse shoulder deformity and a lot of pain in his shoulder. So it really made me think about the importance of preserving pronosupination in radiodysplasia. Many of the patients reported neuropathic pain. Again, this is a patient with thalidomide that we did an ultrasound scan. The median nerve was displaced radially. If I'm going to decompress this carpal tunnel, I need to really think about where the anatomy is. But neuropathic pain is quite a big problem in congenital hands. These are the few points I've mentioned. I think this is a very big topic, but this is all I've got. Thank you.